take about how many minutes to complete her talk?
Uh, Sir, I have made basic, not very much. I have not gone into very much details. So I think
Are you audible?
Yeah. So, good evening to respected seniors and my dear colleagues. Uh, Myself, Dr. Aditya Shete, Junior Resident, PG Year 3 at Apex Hospital, Varanasi, and I'll be moderating the session today. I'm glad to have you all here for this academic meet. Onco Ocean is a premier academic platform for DNB or MD residents having a mission to bring India's finest educators to create a rich learning experience. So today we are commencing with the first session of this meet. To begin with, we will be starting our first module, that is carcinoma breast. And today's session will be dedicated to the topic basic understanding, risk factors, screening, and preventive oncology. Yeah,
Aditya, you have to introduce me.
yes. Just a second, I'm just loading a CV. Just a second, sir.
You don't need to show the screen, just say. That's okay.
Sorry, sorry. So for this session, I would like to welcome our chairperson, Professor Dr. Sunil Chaudhary, sir. He is HOD Radiotherapy and Radiation Medicine, IMS BHU Varanasi. Sir is a renowned faculty in radiation oncology, a life member ICRO, life member Association of Radiation Oncologists of India. A warm welcome, sir.
Thank you, Aditya, for a kind introduction.
I request sir to introduce the speaker for the today's session.
Right. Uh, it's a pleasure to introduce Dr. Prekshi Chaudhary. She had done her had a training at SGPI Lucknow, and she's working as senior consultant at Max Super Speciality Hospital, Noida. So, Dr. Prekshi will be speaking on basic understanding, risk factors, screening, and preventive oncology related to breast cancer. So, this topic is very pertinent. Like we know that the incidence of breast cancer is so high, like the estimated is more than 3 lakh breast patients per year in India itself, and the mortality rate is so high. And we what we get is at usually 60% of patients are at stage 3 or 4 when diagnosed, and we know that prevention is better than cure at any point of time. So, Doctor, I'll request Dr. Prekshi to speak on this topic and she would be taking around 40 minutes. I think you can, if you have queries, I think you can write it in the chat box, and Dr. Aditya would be taking the questions.
Okay.
Welcome,
So
Dr. Prekshi. Yeah.
warm
Thank
welcome,
you.
ma'am.
Thank you, sir. Thank you, Dr. Aditya.
So
Just
I
a
request,
Prekshi,
second.
can
So
it
my
be?
slide is
Yeah,
visible.
yeah, it's visible.
Yeah. So good evening, everyone. And I will like to begin by thanking Dr. Ankita for involving me today here. And I would also like to congratulate her and give my best wishes to her for starting such a nice platform for the students. So, yes, as Dr. Sunil has already told, and we all know that breast cancer is the most common cancer. And in your coming years, you are going to see a substantial proportion of breast cancer cases of in your clinics. So before you treat these patients, before you see these patients, it is very much important to have a basic idea regarding the disease. And this is what the topic of today is. So let us start the subtopics which I have been asked to advise. And basically, this module is made according to the question papers of DNB and MD exams. So the subtopics which I am going to include in this talk today are these. So let us start with the risk factors, the various. Breast cancer, many times the patient will come to you and she will ask, uh, why did I get this disease? Mujhe kyun hua breast cancer? So there is no very definite causal cause effect relationship for breast cancer. But yes, there are certain factors which, when present, they increase the risk of breast cancer. So, what are they? Let us take them one by one. So the most important risk for breast cancer is the gender itself. So being a female itself puts her at a high risk of developing breast cancer. Although male breast cancer is a known entity, but they are very rare and they do comprise only 1% of the total breast cancer cases. 99% are still females. So the most important risk factor is the gender. Second most important risk factor is age. So as age increases, the risk for breast cancer increases, and this increases in an exponential manner. At the time of menopause, there is a slight decline in the rate of risk increase, but the risk still increases, and it begin to decline after the age of 80 or 85 years. So as the age increases, the risk increases. Earlier, it was considered to be a disease of elderly, and majority of the cases were diagnosed after 50 years, after 60 years. But now this disease is being detected in early years also, like the female in their 40s, in their 30s. Uh, and when we compare the Indian patients to the Western counterpart, then Indian patients, they do present a decade earlier as compared to the Western people. So, yes, the risk increases with age, and there is a lifetime risk of 1 in 8. This is the global data. And so, till the age of 49, this figure is 1 in 48. From 50 to 64 years, it is 1 in 25, and it is 1 in 14 from the age group of 65 to 84 years. And the risk declines after the age of 85 years, and it is 1 in 38. So the take home is, as the age increases, the risk increases. But also remember that even a lady in her 30s, if she is presenting with a breast lump, kindly evaluate her properly. Third important risk factor is race. So all the people of Ashkenazi Jewish ancestry, they are at increased risk. In US, non-Hispanic white females have highest breast cancer incidence. The Asian, non-Hispanic Asian females, in such people, it is diagnosed in younger age group. So the black females, they do present with advanced disease, and the risk of mortality is also higher. Then for a very long time, family history has been considered to be a very important risk factor for breast cancer development. So a strong positive family history. A woman who has a second degree relative who is diagnosed with breast cancer, so her risk is about 1.5 times as that of the general population. For one who has a first degree relative, the risk is 1.7 to 2.5. So the risk actually depends upon how many first degree or second degree relatives have been diagnosed, number of the relatives, and the age at which these relatives have been diagnosed with breast cancer. So suppose the relatives are diagnosed with breast cancer at young age, then the risk is more as compared to when they are diagnosed at a later age. And increasing number of first degree relatives, yes, the risk is increased further. Then a woman who has a personal history of breast cancer, uh, if if she had been diagnosed as a case of breast cancer and she received treatment for the same, then the risk of ipsilateral breast tumor recurrence as well as ipsilateral new tumor or a contralateral tumor is increased in such a case. Uh, then, if there is a history of benign breast disease, like history of atypia, atypical ductal hyperplasia, lobular carcinoma in situ, multiple breast biopsies have been done in the past, then definitely that lady is at higher risk, and it has been mentioned to be 4.3 times as compared to the general population. Then, yes, there are certain genes, the mutation in which increase the risk of breast cancer, and the most important ones which everybody has heard are BRCA1 and BRCA2. And so the lifetime risk of breast cancer is 60 to 79% for BRCA1 and 55 to 77% for BRCA2 mutation carriers. So basically, BRCA1 and BRCA2 are tumor suppressor genes and they contribute to the stability of the genome. And whenever there is a mutation, then the risk of breast cancer increases. Apart from breast cancer, the person who is having a BRCA1 mutation, she is at increased risk of ovarian, colon, and he or she is having increased risk of other cancers also, which have been mentioned here. In BRCA2 mutation, apart from breast cancer, there is a risk of ovarian cancer, although this risk is lesser than as compared to the BRCA1. And there is a risk of male breast cancer, pancreatic cancers. So other than BRCA1 and BRCA2, there are other genes which have been found to, if they are having mutation, then the risk of breast cancer increases. And by how much, it has also been mentioned in this table. P53 is another very important gene, the mutation in which increases the risk. So there are certain high penetrance genes, there are certain moderate penetrance genes. So the high penetrance genes increases the risk to a greater extent. Then certain hereditary cancer syndromes are also associated with increased risk, like Li-Fraumeni ataxia, telangiectasia, Cowden's syndrome, Peutz-Jeghers, and neurofibromatosis. Now coming to the reproductive factors. So the early onset of menarche before the age of 10 years or later onset of menopause after the age of 50 or 55 years, they have been found to be associated with increased risk of breast cancer. Nulliparity and age at first childbirth, if the person is older than 35 years of age and somewhere they have mentioned 30 years of age, then the risk is higher as compared to the one who had a first baby before the age of 26 years of age. Breastfeeding has been found to be a protective factor. Now, hormone replacement therapy. So at the time of menopause, sometimes the menopausal symptoms are bothersome, and this person is advised for hormone replacement therapy. Hormone replacement therapy, including both estrogen and progesterone, that is combination therapy, it increases the risk of breast cancer. And the longer the duration of hormone replacement therapy is given, the higher is the risk. In patients who have undergone hysterectomy, in those patients, estrogen alone therapy is given, and it has been found that it is not associated with increased risk. So estrogen alone cannot be given in those patients who have their uterus intact, because giving estrogen will lead to increase in the risk of endometrial cancer. So estrogen only therapy is basically given only after hysterectomy, and it is not associated with increased risk. Another important risk factor is obesity or higher BMI. So obesity is actually associated with a lot of cancers, and in a study they have found that in US more than one third or around one third of the people, they come under the category of obese or high BMI. So the risk of breast cancer, endometrial cancer, and many other cancer increases with high BMI, and BMI of 30 or more. These people, they are at increased risk. So actually, the BMI should be less than 25. Um, Another thing is that this increase in risk of breast cancer with which is due to high BMI, it is seen in postmenopausal women only. So in postmenopausal women, there is peripheral aromatization. That is, the peripheral fat is converted into estrogen, and this estrogen, endogenous estrogen, leads to increased risk. Then physical activity. So these things are correlated actually. So BMI, whenever there is lack of physical activity, then the BMI will be more. So physical activity will lead to reduction in the risk of breast cancer. Then mammographic density is also been has it has also been identified as a risk factor for breast cancer. So one thing is that in dense breast, the sensitivity of mammogram is reduced. But other than that also, the dense breast are associated with increased risk of breast cancer. And they have categorized this density into like it is extremely dense or heterogeneous dense. And as the density increases, the risk increases. Another important risk factor is the exposure of breast to radiation. And especially if this radiation has been given between the age of 10 to 30 years. So suppose for mental field, which is given for lymphoma patients, those patients who have been exposed to radiation, or in multiple diagnostic scans which were done for tuberculosis in uh, previous times. So if there is such kind of exposure, such history should definitely be taken properly from the patient. And what is the implication of taking this history? These patients are at increased risk, and 8 years after receiving radiation, they should be asked to come for screening. So this risk increase start 8 years after the exposure and persist throughout the lifetime. Alcohol intake is also associated with breast cancer risk, and even a moderate amount of alcohol intake is associated with this increased risk. A recent meta-analysis has shown that for every 10 grams of increase in alcohol consumption per day, the risk of breast cancer increased 5% among premenopausal and 9% among postmenopausal females. So coming towards the next part, that is screening. So screening is basically performed in individuals who are healthy in normal population. They do not have any signs and symptoms of breast cancer. And screening is performed so that we can detect the disease early, treat the disease early, and reduce the morbidity and mortality related to this disease. So any abnormalities detected, then further additional views are also advised. Digital mammography, it generates the electronic image and it store as well as process the image, and it can detect subtle changes In a way, in the dense breast and younger female, it has been found to be better as compared to the film mammography. Then use of tomosynthesis. So tomosynthesis is basically, you can say, 3D mammogram. So in this film mammography, two images are taken, while in tomosynthesis, multiple images are taken, and then they are reconstructed to form a 3D view. So by the use of tomosynthesis, the cancer detection rate is improved and false positive rates are reduced. So here you can see that a 2D mammogram, uh, and in many way, the 3D mammogram is better for detection of any early lesion. So the assessment of the mammographic findings is done by BIRAD system, or which is also known as breast imaging reporting and data system, and it has been categorized into 7 categories. So these are from 0 to 6. Important point to note is 0, category 0. It does not mean the test is negative. It means that the test is inconclusive and we need additional imaging to complete our reporting. So 0 does not mean negative. 1 is negative, 2 is benign, 3 is probably benign. And such people, this not patients, such individuals should be asked to come for a short interval follow-up. Then 4 means suspicious, and it is further subcategorized into 4A, B, C. 5 is highly suggestive of malignancy, and 6 category is of a a patient who is a known case of breast cancer. Then screening ultrasound. Second modality is screening ultrasound. Screening ultrasound is not alone, is not recommended as a screening test. And it is usually done to supplement mammography. So basically, in patients who have dense breast, mammogram is not a very good modality, and adding ultrasonomammography, is a better choice as it improves the sensitivity from 50% to 77.5% as per a study. Then screening MRI. MRI routinely is not advised for screening. It is advised for high risk patients or if we have equivocal findings on mammography and ultrasound. So the high risk patients who have strong family history, who have a high risk of breast cancer as per the models, which I'll discuss in the later slides, then who have genetic predisposition, who have history of receiving radiation in between 10 to 30 years. All these individuals, they are at high risk of developing breast cancer, and an MRI is recommended in such individuals. The sensitivity of MRI is better than mammography, but its specificity is lower. Contrast enhanced mammography. So here there are patients who for whom either MRI is not available, they are not affordable, or because of claustrophobia they are not undergoing MRI. So for such patient, contrast enhanced mammography is an alternative. It is not routinely recommended. It is recommended in those patients who have high risk of recurrence or who have mammographically dense breast. So basically, IV iodinated contrast is given, and this contrast enhances the tumor vascularization, and it detects the lesions better as compared to mammogram. So, okay, so now we know that screening is important. Now we know that what are the tools of breast cancer screening, but how to use these tools, in which patients, which tools should be used. So for that, we need to know what is the risk. We need to categorize the people into whether they are average risk or they are at high risk of breast cancer. So this risk assessment ideally should be done by 25 years of age, and that women should definitely be explained regarding the benefits, the risks, and the limitations of this risk assessment. After we have categorized that this person is at average risk or at increased risk, now we'll start the screening recommendations. So an average risk individual uh, before the age of 39, so she should be asked for a clinical encounter every 1 to 3 years, in which she should be explained regarding risk reduction and lifestyle modifications, And the clinical breast examination should be done every 1 to 3 years. Then these individuals, they should be aware of their own breast consistency, any changes in the breast. So if they perceive any changes in the breast, then they should report to their clinician immediately. After the age of 40 years, in average risk individual, apart from all the other things which we have discussed in the previous slide, we need to add annual screening mammogram with tomosynthesis. And those who are having dense breast, supplementary imaging should be added. Then those who are at increased risk. So basically, they should have a clinical encounter every 6 to 12 months, which should begin at the age which is identified as being increased risk. Then annual screening mammogram should be advised 10 years prior to when the youngest member had been diagnosed with breast cancer, but it should not be done earlier than 30 years of age. Annual MRI also should be done started 10 years prior to the youngest member, when the youngest member had been diagnosed, but it should also not be done before the age of 25 years. So some people, they recommend alternate MRI and mammogram. uh, then for females who have received radiation 8 years after she receives radiation, the annual mammogram should start, but it should not be started before the age of 25 years. So these were the NCCN recommendations which we have discussed till now. And these are various recommendations by ACOG, ACR, and US Task Force, all these. So they do not differ much. Basically, you need to know when should you start screening. Then you should know the interval at which it should be done. Then another important thing is what is the age at which the screening should be stopped. So NCCN does not recommend any upper limit at which the screening should stop. Basically, it should be individualized. So we should see the risk benefit ratio. What suppose if a lady who is elderly, whose life expectancy is less than 5 years, who is having multiple comorbidities, so we are not going to gain much by detecting a lump. So we should, it is to be individualized, and there is no upper age limit described by NCCN for stopping the screening. Now, molecular classification. So earlier, the treatment of breast cancer was done based upon the clinical and histopathological factors, like what is the age of the patient, the tumor size, the nodal status, the grade of the tumor. So all these things were considered while deciding the treatment of the patient. But it was found that many patients who were early stage, they did not fare properly. They tend to relapse earlier. Many patients who were diagnosed in locally advanced stages, such patients, they respond nicely to the treatment. So it was then realized that breast cancer actually is heterogeneous, and apart from the clinical and histopathological features, there must be something else which is deciding the course of their which is deciding the response of these patients to the treatment. So, keeping these things in mind, Peru and Soli et al. In 2000, they published their seminal work, and they described four molecular subtypes of breast cancer based upon the intrinsic gene expression patterns. So, they divided in breast cancer into luminal, HER2 enriched, triple negative, or basal like, and normal breast like. So, luminal was further divided after research into luminal A and luminal B. Some other subtypes have also been described. So I will start first of all with the luminal A. So this is the most common molecular subtype, and it comprises around 50 to 60% of the newly diagnosed breast cancer cases. They basically have high expression of cytokeratin 7, 8, 18, 19, which are the characteristic of luminal epithelial cells of the breast. IHC wise, they are ER positive, PR positive, HER2 negative, low Ki67. They are of low grade. Low grade lesions include an IDC, mucinous, tubular, cribriform, classic ILC. So all these low grade lesions, they usually come under luminal A. Then this subtype has a very good prognosis. The course of the disease is very indolent, and they do go to nodes rarely. They may go to bone, but going to the visceral sites and brain, so it is rare. So this is a good prognostic uh, classific class, and they respond nicely to endocrine therapy. They do not respond very nicely to neoadjuvant therapy. So coming to luminal B, so all the luminals were not equal. Luminal B is the aggressive form of ER positive breast cancer, and they are ER positive, PR negative, HER2 negative, and the Ki67 level is increased. So they are of moderate grade, intermediate. The prognosis is intermediate between luminal A and HER2 and TNBC. So the main difference between luminal A and B is that in luminal B, there is increased expression of genes which are related to cellular proliferation. Another comes HER2 positive, HER2 enriched. So they make around 15 to 20% of the newly diagnosed breast cancer cases. They are HER2 positive, ERPR negative, high Ki67, um, high grade tumors, proliferative index high. They tend to metastasize to brain as well as to visceral organs, and the prognosis is poor. Uh, but they do respond well to anti-HER2 therapy like trastuzumab and lapatinib. The HER2 positive tumors, they also have been found that they have increased sensitivity to doxorubicin, and they are relatively resistant to hormonal agents. So coming to the fourth category, basal-like. So they are 8 to 37% of all the breast cancer cases, and they are also high grade. So they are positive for CK5, CK14, CK17, and laminin. They do not express ERPR HER2. So many times they are referred to triple negative. Although it is very important to clarify here is that triple negative and basal like are not completely synonymous. They there is around 20 to 30% discordance, and triple negative is described based upon the IHC, and basal like is described depending upon the basal myoepithelial markers. So triple negative, since it has become one of a very important subtypes, so we should discuss it. So yes, ER negative, PR negative, HER2 negative, high Ki67, and mostly they are IDC. They also include medullary, metaplastic, and apocrine carcinomas, and it has been seen that TNBC, they are more prevalent in BRCA1 mutation. They are more seen in young women. They have high grade, and they have poor prognosis. TNBC has further been subdivided into seven different categories, and I'm not going into the details of these. Normal breast-like, although it was identified by the like Peru and Soli, but actually there's not much relevance. It is poorly characterized, and there's not much relevance of discussing or categorizing it. So it is not much talked about in recent times. So there are certain treatment implications also, which we'll discuss further in the further slides. Then tumor markers. So what are tumor markers? They are the substances produced by tumors or the body's response to tumor. They play a role in screening. They play a role in making a diagnosis, deciding the prognosis of a disease, predicting response to a particular therapy. Then response, they are also used for evaluating the response to the treatment, and they are also used as in surveillance to detect the recurrence at an early stage. So the most important predictive and prognostic marker for breast cancer is estrogen receptor. It is a nuclear receptor, and if the value is between 1 to 100, then we say that ER is positive. 1 to 10 is low positive ER, and those who it is mandatory to advise this test, and it is done by immunohistochemistry. So it is recommended in all the newly diagnosed breast cancer cases. Those patients who are ER positive, they have a favorable prognosis. And so so basically, one more thing, that those patients who are weakly ER positive, that is low ER positive, 1 to 10%, endocrine therapy is advised in them also. But many people say that they behave more like ER negative, although they should be given a benefit of doubt, and endocrine therapy should be advised to low ER positive patients also. PR is another member of the nuclear receptor family. And so those patients who have ER positive tumor, they show PR positivity in 80 to 90% of the cases. So if a tumor is ER negative and PR positive, what to do? So they may be considered for endocrine therapy, but the data of this usage is limited. We don't know how much benefit the patient is going to get. Another important marker is predictive and prognostic is HER2. It is a member of human epidermal growth factor receptor family. And basically, um, this HER2 positivity is seen in 13 to 15% of the cases. And whenever it is present, the prognosis is not so good. They are aggressive tumors of metastatic potential. And the test is done by immunohistochemistry. It will give the result 1 plus 2 plus 3 plus 1 plus is clearly negative, 3 plus is clearly positive, 2 plus is equivocal. And whenever it is equivocal, please advise for FISH. So anti-HER2 therapy, now we have multitude of them. So there are HER2 monoclonal antibodies like trastuzumab, pertuzumab, margetuximab, such a tongue twister, TKIs, lapatinib, tucatinib, neratinib. ADCs are newer drugs, TDXD and TDM1. So there are many therapies related to the HER2 receptor. Then comes the surveillance and monitoring of disease. So suppose the treatment of the patient is completed and she's kept on surveillance. Many studies, they have said that CA 15.3 and CEA, they should be used for surveillance, but there are certain problems related to them, like you can see the wide range of sensitivity here, 32 to 90%. So this wide range is because different cutoff levels have been used in different studies. One thing. Second thing, that in early stage breast cancer, their values do not increase significantly. And whenever their values are raised significantly, then the disease is either loco-regionally advanced or it is metastatic. Third important thing is that both these markers are not very specific for breast cancer. CEA is raised in colorectal cancer, pancreatic cancer, and many non-malignant conditions also. Likewise, CA 15.3 is also not very much specific for breast cancer. So their use has been recommended by some papers, but NCCN, ASCO, ESMO, they do not advise the use of CEA or NCA 15.3 on a routine basis. So another important topic, I don't know whether it will come under the this tumor biomarker, probably it will come, but this is molecular genomic testing or genomic assays. So genomic assays, around 60 to 50, 60, 70, I don't know what percentage of early breast cancer patients, they do receive chemotherapy. Substantial, yes. So whether all of these patients, they do get benefit by this treatment, don't know. So it was thought that why not to stratify which patients are going to get benefit from chemotherapy in early stage low risk breast cancer and which are not going to receive any benefit, and why not to omit chemotherapy in such subset. So because of this molecular testing, it came into role. Nowadays, there are multiple commercially available tests like Oncotype DX, MammaPrint, PAM15. There are many tests. So this is basically the test is performed on core biopsy or surgical specimen. The techniques are complementary DNA, multiplex, PCR, among others. And so, will you advise these tests in all the patients? No. only in low-risk breast cancer patients who are hormone receptor positive, early-stage breast cancer, HER2 negative. Uh, so earlier, these tests were advised only for node negative patients, but now there are many papers which have used these tests in node positive patients also. So we'll discuss the most common type, oncotype DX, and so this basically is a 21 gene RT-PCR based assay, and it is done for genes which are related to proliferation, ER, and HER2 signaling. So depending upon the result, it can be a low, the recurrence score can be either low, intermediate, or high. So its usage has been validated in Taylor-X trial, and the recurrence score is from 0 to 100. So those who are having low risk, low recurrence score up to 10, they are definitely not candidate for chemotherapy. We can omit. Those patients who are having high recurrence score, more than 26, so more than or equal to 26, they are definitely candidates for chemotherapy. So the intermediate 11 to 25 risk score, what should we do? So in Taylor-X trial, these intermediate risk patients, they were divided, they were randomized either to receive endocrine therapy alone or to receive endocrine therapy along with chemotherapy. So this trial concluded that in women who are older than 50 years of age, there is no benefit of giving chemotherapy in the risk score 11 to 25. In women who are less than 50 years of age, adjuvant chemotherapy is beneficial if the recurrence risk score is more than 16, right? And as the risk score increases, absolute benefit also increases. So these are the various tests which have been advised, and among them, category 1 recommendation are Oncotype DX and MammaPrint. Now coming to prevention. So seeing the morbidity, yes, you can say that the mortality of breast cancer is not that much high, but seeing the absolute number of the patients, yes, the absolute morbidity and mortality is definitely high. So we should do something to prevent this cancer. For that, we will just revise quickly what are the levels of prevention. The levels of prevention are primordial when it is for the entire population, and only the risk factors are not there, the disease has not occurred. So we in the primary, what we do, we just identify a susceptible population and we prevent a disease from occurring. Risk factors are there, so we try to limit the risk factors. We try to limit the risk exposure, and immunization, vaccination is an important example of primary prevention. In secondary, the disease has already occurred. The patient has not become symptomatic. It is still in the subclinical phase. So here, what we can do, we can detect the disease early, and we know that early detection leads to better treatment outcomes. Screenings are a form of secondary prevention. Tertiary, the patient has already is being symptomatic, is already diagnosed. We just want to reduce the severity of the disease and the treatment related outcomes. Then quaternary prevention has also been explained. It is the prevention where action is taken to protect the individuals from medical interventions that are likely to cause more harm than good. Now, what should we do to prevent breast cancer? Basically, there are three things to do. We can either advice for lifestyle modification. We can see the risk factors which we have discussed earlier. They can be divided into modifiable and non-modifiable risk factors. So all those modifiable risk factors, they can be targeted for primary prevention of breast cancer. So what are those factors? Dietary factors. So the person should be advised to avoid junk food, processed food, high fiber diet should be taken, fruits, vegetables, like everybody knows. Exercise, definitely it reduces the risk, avoiding alcohol, tobacco, and exogenous female hormones, the use should be limited. So now, so which individuals should be advised which tools and how to assess the risk. So for risk assessment, we have various models. They take into account the family history. Some models, they take into account the personal history. So they assess the risk. So this risk factor, like Gale model, this is the most common one, Tyrer-Cuzick. So they are used to assess the risk of a particular individual. And after that, if the individual is at average risk, normal risk, then lifestyle modifications will do. But if they are at increased risk, then there are certain risk reducing strategies which have been described in literature, which reduce their risk of breast cancer. And these are chemo prevention and certain risk reducing strategies. So, like all the lifestyle modifications we have discussed, maintaining healthy BMI, exercising, and uh, so all these things. Now, the risk reducing agents. So, four risk reducing agents have been described, which are tamoxifen, raloxifene, anastrozole, and exemestane. So, in which patients should we use these risk reducing agents? The individuals who are more than 35 years of age, who have a Gale model breast cancer risk of 5-year risk of more than or equal to 1.7%, or by the Tyrer-Cuzick model, the 10-year risk of more than 5%, or a history of lobular carcinoma in situ. In these patients, the possibility of risk reducing agents administration should be discussed with that person. So, tamoxifen is the only agent which can be used for premenopausal, and rest others can be used in the postmenopausal only. Um, what is the dose which should be given? It is 20 milligram per day. It can be given in premenopausal and postmenopausal. And so actually it is associated with certain side effects like hot flashes, invasive endometrial cancer, pulmonary embolism, cataracts. So suppose if the patient is not tolerating the drug well, or there are certain issues, so low dose tamoxifen is also an option, 5 milligram per day or 10 milligram every alternate day. Uh, if the patient is having symptoms or side effects on 20 milligram dose. So these are the NCCN recommendations. Then raloxifene. It is tamoxifen is the first generation SERM, and raloxifene is the second generation. So so it has similar anti-estrogenic effects, and but the side effects of raloxifene, the endometrial stimulation of raloxifene is lesser as compared to tamoxifen. So those patients or those individuals who have increased endometrial thickness, and it is and we want to give her the risk reducing drugs, then raloxifene is better in such cases. However, efficacy wise, tamoxifen is better as compared to raloxifene. The dose is 60 milligram per day. Both of these drugs, they reduce the breast cancer risk incidence by almost 50% over 5 years of treatment. Uh, then AI. AI, basically, I think they're not FDA approved, but NCCN recommend AI, anastrozole and exemestane. So the dose is 25 milligram per day for exemestane and 1 milligram per day for anastrozole. And the reduction post-menopausal women, it occurs by 53 to 65%. Then the side effects which are related are muscle pain, joint pain. So bone related issues are there with AIs. Hot flashes, yes, they do occur here also. Now, coming to risk reducing strategy, surgery, sorry. So, which patients are candidate for risk reducing surgery? If they have a strong family history, and they have a genetic mutation like BRCA1 or BRCA2 positive, those who have received chest wall irradiation. So if there is not strong family history, then there is no established benefit of risk reducing mastectomy in individuals, even with genetic mutations. Then what are the surgeries? Bilateral risk reducing mastectomy reduces the risk of breast cancer by 90%, and bilateral salpingo-oophorectomy reduces the risk of breast cancer by approximately 50%. It is similar to that of the drugs which we have discussed, tamoxifen and raloxifene. So Now, something about genetic testing and genetic counseling. So, we are seeing that a lot of genetic mutations are associated with breast cancer. So, in which patients should we advise genetic testing and what counseling should be done before we advise this test? So, let us see what are the indications of genetic testing. If there is in family, if there is a personal history of breast cancer diagnosed before the age of 50 years, triple negative breast cancer, which is diagnosed at any age, not young, even if individual, she has 60 years of age and she is diagnosed with triple negative breast cancer, then genetic testing is indicated. Then those who are having a relative who is already diagnosed with BRCA mutation, those who are having family members who had breast cancer, especially male breast cancer. It is a very important indication. Then who have both breast and ovarian cancer, the Ashkenazi Jewish ancestry. Then if there are multiple family members having multiple cancer diagnosis or in or personal history of having multiple cancers, then the family history of any inherited cancer predisposition disorder. So all these patients or individuals, they become candidate for genetic counseling. This is the NCCN recommendation. You can see that treatment indications are also there. So if there is any metastatic or high risk HER2 negative, triple negative breast cancer, triple negative as such, they are advised for genetic testing. So there are treatment recommendations also. They can be treated with PARP inhibitors if they are found to have genetic mutation. So more or less, that was an easy indication chart, and this is mostly we have covered it in the earlier slide. So whenever you need to want to assess a risk in a person and do the genetic testing, it basically includes three stages: pre test counseling, which is done before you order the test; then which test should you advise, second step; and after the results are disclosed, then post test counseling should be done. So what should be done in pre-test counseling? You basically educate the patient regarding what uh, risk, what benefit she is going to have by doing this genetic testing, what intervention can be done if the results, what results can come. So there are many things which you need to discuss with that person whom you are advising the genetic testing. And so the person should have a knowledge what genetic testing she is being advised for. Then what are the various cancers, the risk of which are increased if the result is positive? What is the goal of this risk assessment? A detailed family history has to be taken, detailed personal, surgical, medical history has to be taken, physical examination, keeping in mind the familial syndromes, should be done before we advise the genetic testing. And after that, you should tell about whether what are the outcomes of the testing. It can be positive, which may be pathogenic or likely pathogenic. It may be true negative. It may be inconclusive, which is also known as VUS, uncertain, uncertain. The results are uncertain. And so they should know about what are the possible outcomes of the testing. All these things should be done only after a written informed consent has been taken. It is very important to have a written informed consent before you advise genetic testing. Then you should also discuss the plan that when we are going to dis discuss the results. Uh, and then what are the management options if pathogenic or likely pathogenic is identified? What is the cost of genetic testing? And uh, the risk to the relatives is also discussed. So many things are discussed and it is very important. The pre-test counseling is really important, and medical legal issues, they are also being discussed. So multi-gene testing, uh, it is based upon next generation sequencing, NGS, and by this we can analyze many genes at the same time. So BRCA1 and BRCA2 are the most common gene which are associated with breast cancer, but we have seen that there are multiple other genes also. So a comprehensive analysis of the genome is done at the same time in multi-gene testing. And so these are this is probably the repetition of a previous slide. So after the results are disclosed, the results come out, then we have to do post-test counseling. We will discuss the result with the patients. We'll discuss the various medical risks which are associated with the results, and what are the possibilities, what risk reducing strategies. If we identify a particular mutation, then what risk reducing strategies we can uh, go ahead with. So medical options, surgical options, and importance of notifying family members. So all these things are basically discussed in post-test counseling. So with that, I would like to thank you for patient listening. Thank you.
Uh, Thanks, Dr. Prekshi, ma'am. It was a great presentation, ma'am, covering the minute details of the topic. So it was a fruitful experience to all the participants. Thank you, ma'am.
Thank you.
I request Dr. Sunil sir to add few words of enlightenment to summarize today's topic.
So there is
Take it.
one question in the QA box. They
There are
have asked.
several questions. Yeah, there are
There are
several
several, yeah,
Oh,
questions.
okay,
one,
sir. Okay.
Yeah,
so
there
I
are
will,
several questions. I think Aditya will take them uh, one by one.
okay, sir.
So I think it was a very lucid and comprehensive talk, Dr. Prekshi, and I hope everybody learned a lot from your lecture. Aditya, you can take the questions one by one.
Okay, sir. Yeah. So the first question is, what constitutes family history in terms of breast cancer, like mother, sister, and who others?
So mother and sister, basically they are first degree relatives. So if there is a positive history in first degree relative, the risk is increased 1.7 to more than 2%, 2 times. And even in aunt, like Mosi, Nani. So if they have a family history in these individuals also, then it also increases the risk. There are some studies which says that even in paternal aunt, Bua. So if there is a positive history, then it increases the risk. And the number, you should take care of how many members have been they have been diagnosed with breast cancer, and what is the age at which they are diagnosed. So all these things should be kept in mind.
Yeah, so the second question is, what measures and cautions to adopt if genetic mutation is found? And should we do BRCA1 and BRCA2 only for patients or other the family healthy members?
So actually, genetic testing is very important. So before advising genetic test to a patient, we should be very cautious, because if they come out to be positive, if there is genetic mutation positive, then we need to advise certain risk reducing agents or risk reducing surgery to these people. Whether they will be compliant to that, how they are going to accept that. So there are many psychological issues, many medical legal issues. So if there is any genetic mutation, then those people definitely are at higher risk. They can be advised for chemopreventive agents like we have discussed, tamoxifen, raloxifene. And if we think that there is substantial risk, there is very high risk of developing breast cancer. Apart from BRCA mutation, we have to uh, see other risk factors also. We have to accommodate all the risk factors. And so if there is very high risk, then reducing surgeries can also be discussed with these patients. So after completion of family bilateral salpingo oophorectomy, so can be done. Bilateral mastectomy can be done depending upon the risk that particular patient is having. Only BRCA positive is not sufficient.
How does the counseling in your hospital? Yes, counselors for pre-testing and post-testing, or you do it yourself, or the surgeons does it?
So basically, being radiation oncologist, we are not regularly advising genetic testing. Yes, I know many people who are genetic counselor, not genetic counselor, they are um, geneticist, I don't know what. So there are many doctors who are doing all these things on a routine level.
Okay. So you ask NGS or you ask for BRCA? Just BRCA or NGS?
So NGS is better, like the cost is now less as compared to what it was previously. So
Hmm.
it will give a better comprehensive analysis.
So what do you routinely ask? For NGS or BRCA?
And NGS is better, sir, I
Okay.
suppose.
Yeah.
So next question is why postmenopausal obesity is important as a risk factor?
So in postmenopausal female, the estrogen release of estrogen from ovary is reduced, right? So the source of estrogen in postmenopausal female is peripheral fat. There, the fat is converted into estrogen, peripheral aromatization. So that's why it is important for postmenopausal. Obesity is important for postmenopausal females.
Then significance of Ki 67% and clinical implications.
So Ki 67 is a proliferation marker. And like we have also seen in luminal, if it is less than 14%, although different people have categorized it, the value is not hard and fast. So if it is less, luminal A less than 14%, then it is luminal A. More than 20 in HER2, it was more than 20%. So as the value of Ki 67 increases, the tumor is becomes more aggressive.
In the last,
But Ki 67 alone is not a factor which is used for deciding treatment.
so role of breast self-examination as a screening tool.
Breast self-examination, actually, it has been compared. Although I would say that yes, woman should be aware of the breast, any changes in the breast, and whenever in the uh, any relative of a patient or any patient, they ask you, you should always ask them to do a regular self breast examination. If she's premenopausal, then you should ask them to examine their breast on the fifth or sixth day of the menstrual cycle. At that time, the breast consistency is such that the changes are appreciated better, right? In postmenopausal, they can be asked to fix a date, and on that date they should do self breast examination. But on studies doing a self breast examination, so we don't have any data that it is beneficial. But obviously, you encounter patients in your clinic many times, uh, they appreciate any lump in the breast by themselves and then they go to the doctor. So self breast examination should be advised to patients.
Then the question is BRCA testing routinely recommended for TNBC patients?
Ideally, it should be. So it is an important indication of BRCA test.
Um, so that's
It governs your adjuvant treatment as well. Like,
Yeah. So they become sensitive to PARP inhibitors, and they have inherent sensitivity to platinum group. So therapeutic implications are also there.
yeah.
right.
Are there any guidelines for BRCA testing in TNBC patients?
I don't get it. Guidelines meaning by?
Yeah, NCCN
Of
recommends it. Like
evidence.
it's,
So we have for genetic testing, there was a slide from NCCN. Yes, NCCN.
Next is what can the treatment options for normal breast tissue like histopathology? Are they treated on the same line as luminal A?
So actually, they are very low grade tumor, and um, at one or two places I got the normal breast like. Otherwise, they are not even mentioning it normal breast like. So they are they have very low grade tumor, they are more like normal breast. So that's why the name normal breast like. So if there are, and so yes, they should be treated according to luminal A only.
Okay. Uh, does healthy family member like mother and sister need BRCA testing?
So if there is any uh, member who is if the patient is BRCA positive, then yes, all the other members in the family, they should be advised for BRCA testing. What say, sir?
Yeah, yeah, absolutely. Like, the inheritance is autosomal dominant, right?
Yeah, yeah.
I think we don't have any more questions.
Yes, sir.
I think we should wind it up. Ankita, you want to say something before we wind it up?
Yeah. Thank you, Prekshi ma'am, for your insightful presentation, and Sunil sir for guiding us throughout, and to all the participants for their attention and engagement throughout the session. I would like to request please subscribe to the channel. If you have any query or any question, you can just put in chat box and we'll request our speaker to answer you whenever she finds it. I mean, maybe later on. So, and you are free to give us feedback, and we'll definitely try to add more topics which will be beneficial for your exams. And yeah, that's it. Thank you once again, ma'am and sir.
Thank you, Dr. Ankita.
Congratulations, Ankita,
Thank you, sir.
for taking this initiative. Like, I think it will be of great help to the students.
Thank you, sir. There is one question chat box. Somebody is asking when is the next session. So these sessions will be on every Wednesday, 7 p.m. onwards. It can be till 8 or 9, depending on the length of the talk. And can we get the presentation? Actually, the presentation and entire video will be freely available on YouTube. So you can just go and download from there.
Thank you.
So on this note, I would like to conclude this session by thanking Dr. Prekshi ma'am and Dr. Sunil sir. Thanks a lot, ma'am.
Thank you,
Thank you,
Aditya.
everyone. Thank you, sir. Thank you, Dr. Ankita.
Thank you. Right.